There's no sleeping now that your tummies are full, hey? I'll keep my eye on you. So thank you, everybody. I'm going to attempt to talk about engaging leadership with QI. But I think I want to preface my comments on saying that everything that I speak about and what I'll be presenting to you today is really based on years and years of frustration in the field of QI. I think sometimes when you see us present and we come with all these wonderful answers, it's not because we learned them yesterday. It's taken years and years and years to come to a deep understanding of health systems and where we are. So, slides, please. Okay. I think I'll just carry on while you try and bring up the slides. I think that engaging leadership is crucial because in my view, no change can take place in a health system without the management buy-in. And so managers really are responsible not just for the implementation, but are responsible for building the health system so that the health system can be open to change. And I think managers all too often spend their time focusing in on individuals as the source of the problem instead of focusing on the system as the source of the problem. Next slide. Next slide, please. So I want to mention three things, just three things right now that I feel are imperative for engaging leadership. The first one, it has to be data-focused. If you are not God, please bring data. Because we trust God, everyone else, bring your data. And I think all managers and leaders should operate in a very similar fashion. We cannot be making big changes based on gut feeling, based on what I feel is going to be right. We must bring the data to the table. And I believe that responsible senior managers will do the same. And so the first way to engage our management is show them the problem using data. Next slide, please. The next point I want to touch on is that I think that as quality improvement enthusiasts, we can get lost in jargon. I believe that we can get lost in all sorts of theories and we can get lost in giving people way too much information. So we need to keep it simple. So you need to find that sweet spot. You need to find what is relevant to engage the managers with. Because they don't have time to hear the whole long story. They want to hear the crux. They want to hear what's relevant to me. They want to hear what's relevant for my program. So it's very important that our preparation takes place well before we start engaging with our leadership. You must be clear about what it is that you want to get from that conversation, what it is you want this person to do, and pitch your point according to what it is that you want to get out. So really try and streamline it and be as relevant as possible. Next slide, please. I think this one is also really crucial, is that when dealing with managers, it's almost like we want to cut and paste what has been done before. And we want managers to conform to what we know is textbook quality improvement. But being and understanding a context is crucial. How a program or how we implement quality improvement in each of our contexts is going to be slightly different. We must get the principles correct. We must get the concepts correct. But there must be adaptation in implementation. And we must allow each manager to create some of that adaptation for themselves. So Yesterday, I spoke to you about those 7 problems that have really been keeping me up at night and helping me to process what I think we need to do differently in the field of quality improvement. Next slide, please. And I feel that I've spoken to you a lot about systems, and I feel that approaching leadership must be also seen through a leadership lens, because there's leadership at every level of the health system. And I think that we get too focused in on maybe only engaging the national leaders, or if we want to do something in a specific province or region or area, we focus in on the leaders within that region or that area. But actually, the change that we are all trying to bring about requires a change in the health system. And so we need to make sure that leaders at all levels in the health system are engaged, and that includes the facility leaders. Because if we are going to bring about a systems change, we need to ensure that all of those leaders are being engaged. Next slide, please. So with my systems view, I have come to understand that true sustainability begins at the beginning of a project, because it has to be embedded into the fabric of daily work. And so if we want our quality improvements efforts to be lasting, if we want our quality improvement efforts to have an impact within our health system, we need to work with managers to embed that into the fabric of everyday work. Otherwise, ladies and gentlemen, we just take on once again a project focus that has an end date, a beginning date, and an end date. And when it is done, it is done. And we cannot approach quality improvement as a project. It has to become embedded within our daily work. Next slide, please. So currently, I'm funded through a Bill and Melinda Gates Foundation grant, and they are paying myself and a team to base ourselves at the National Department of Health to support and help improve the HIV program in South Africa. And when I started at the National Department of Health, they asked me to really look at what is called the nerve center strategy in South Africa. And basically what was happening is when South Africa was tasked with achieving, as you all are, through the UN AIDS, the 1990 goals, there was a lot of influx of money, as you can imagine, in South Africa being the biggest HIV program. But many managers didn't know how to cope with this influx of money, with the raised expectations of how do we manage all of this and all of the activities that come along with it. And so a project management arm within the National Department of Health and in the HIV cluster was formed called Operation Phuthuma. And Operation Phuthuma used nerve centers, which is a management room type approach where people come together at the various levels of government to coordinate their efforts around what they are doing within HIV. And so when I joined, my first task was to go around the country and form parts of these nerve center meetings. But what did I learn, crucially, that has now led to the design of what I will show you today? Is that these nerve center meetings were just forums where people were reporting ad nausea. Everyone would have their 5 minutes of fame. They would stand up, they would present their PowerPoint presentations, we would clap hands, and then we would sit down, and at the end of that, absolutely nothing changes. And so for an improvement-driven person like myself, I nearly went nuts. And I thought, we cannot do that. We cannot just keep talking about change. How do we coordinate this? And so I was given the opportunity to change the nerve center approach to give it a quality improvement framework. And so what you see on the right-hand side is the manual that has been produced to introduce a systems approach to quality improvement. Next slide, please. Because this systems approach was born from frustration of doing PDSA cycles in thousands of facilities around South Africa for years and years within the health system, within the criminal health system. We were doing it everywhere. But I would go back 6 months later or a year later, and the improvements that we enjoyed then were no longer there, were no longer sustainable. And I thought that this madness has to stop, because we had these individualized activities, these individual PDSA cycles, these individual projects that were all running in these facilities, but they weren't leading into a systems change. Next slide, please. So as I looked at what it is that we needed to do differently, it was very clear that we were not going to go down the project route, that we had to, if we were going to make it sustainable, embed quality improvement within the fabric of the work. And so it needed to be embedded within how managers work, and it needed to be embedded with how we deliver services. Next slide, please. We also needed to ensure that we provide the training that was required. We needed to provide the tools, practical tools that were needed. We needed to help people develop the skills and the confidence to do things differently. The tools were critical because we felt that in delivering healthcare, it has become incredibly complex, and that there are no real implementation guidelines for the healthcare workers to draw from. We are great at delivering clinical and developing clinical guidelines, but we do not do anything about implementation guidelines. And so I wanted to try and demystify implementation and give a lot more guidance, specific guidance, around if we are going to implement, if we are going to bring about a change at a systems level, how do I now embed it? Next slide, please. We had to develop the IHI dosing model where we list all of the cadre of staff that we wanted to form part of this and list what it is that each one required and built that into the model. Next slide, please. So eventually the model came out based on, next slide, please, on the 4A model that I presented yesterday. The entire framework for our health systems change is built along the 4A model, where we are trying to teach people the basic arts and understanding of how we assess problems, how we understand why they are occurring, so that we can act differently, that we can then analyze our work and anchor it into our system. You may ask, of course, where does the PDSA cycle fit into this model? Well, it is firmly placed within the ACT part of it. PDSAs is testing, as Ernest explained to us earlier, new ideas. What I found was missing was a framework, a larger framework of how we pitch all of our work, how we see all that we do, and not just testing new ideas. So it was important that we develop this framework that was helping with the systems change and not just testing new ideas. Next slide, please. So in the Operation Phuthuma Nerve Center approach, what we have done, and this is an example of one of the provinces in South Africa, at the heart of that, you will see that we have identified one facility who needs, you'll see it's called Heidedal facility, who needs serious intervention. Heidedal facility, if we are going to bring about a change in Heidedal facility, you will see they will need to be supported by their sub-district, which is Bloemfontein Health Sub-District. If that sub-district is going to bring about the change it needs to be supported by the district, which is Mangaung District. And if the district is about to bring about the change, it must be supported by the province, which is the Free State Province. So this is what I mean by systems approach. We cannot just work in that facility. We have to ensure that every level of government that is involved with that facility, that is employed to support that facility and deliver healthcare services for the patients within that facility, are also capacitated to do what they need to do. Next slide, please. So we then, in our model, had to design what we were going to do at every level. We are not a lot of people. I have 15 staff members on this grant who are working solely from national level all the way down to facility level for the entire country. So we had to have a look at our mentorship model and say, right, what are we going to do and how we are going to do it? If we are going to engage these managers, if we are going to implement, if we are going to embed quality improvement work, what do we need to do? And so we needed to focus on the behavior change of managers. We were not prepared to work in any province, we are not prepared to work in any district if the senior managers are not prepared to work with us. Because no work will get done. We can take people to the water, but we cannot make them drink. And it is only in the drinking that the patients will receive the change. So we only go to provinces right now that come on board and want to work with us. We help them to make the adaptations that they require. We come with the package, we show them what needs to be done, but they have to be responsible for the adaptation. We counsel them, we guide them, we help them to develop their strategy, and we help train master trainers in each of the provinces and districts in which we work. Next slide, please. So what I would like to do is just show you very quickly what are the high-level things that we are trying to do to embed quality improvement in the health system so that we are embedding it with our leaders. At a management level, what are the 3 things that we are focusing on? Next slide, please. There are 3 main things that we are focusing on at present at a management level. These people are cutting my time short now. How do we get our managers engaged and engaging? 3 things. We have to help them to change the kinds of support that they give at a facility level from audit-driven to supportive supervision. Number 2, they have to focus on drivers of program excellence, which are based on the WHO building blocks. It's about how do we take a systems view to our work so that we don't just develop activities, but that we develop drivers of program excellence. The third one is how do we create nerve centers that are problem-focused and improvement-driven. Next slide, please. So as you can see, supportive supervision is not a red carpet event. We are trying to change that culture of a red carpet event to a supportive visit. Next slide. We have provided some very specific tools for supportive supervision. It's a tick list which managers can consult as they go to facilities to help them to feel confident about how they provide support. In my experience, managers, as I've sat down with managers from province, national, and district level, all of them said, well, we're not exactly sure what it is that we need to do. And so to try and help facilitate the process, we listed a number of things that they need to do when they get to the facilities. Next slide. Our drivers of program excellence, as I said, are embedded within the drivers of the WHO building blocks. And so we help managers to look at all 6 of these drivers so that when they are implementing programs, these things are considered before activities are implemented. Next slide. In conducting nerve centers, we have given a suggested framework of what a nerve center needs to look like, what are the things that they need to discuss, how do they prepare for that. Next slide, please, so that our meetings now are seen as meetings as a process and not just a sole event. That they need to see these nerve center meetings that require a large amount of preparation, that require you to look at your data, that require you to understand what is happening, what activities are taking place, so that the meetings are conducted with a lot more efficiency, and that post-meeting we carry out what it is that we said that we would do. Next slide, please. Next slide. At a facility level, I want to touch very quickly on what it is that we're doing. We formed multidisciplinary teams, indicator teams, so that these indicator teams, next slide please, can take on the responsibility of improving these indicators. So we have provided suggestions of who should be part of those teams. Note, they are not just clinicians. We make a vital error in our health systems when we think that the only people who should be trained in quality improvement and doing quality improvement are our clinicians. We must look at the multidisciplinary teams. Next slide, please. These multidisciplinary teams are given tools and they are provided with a process of what they need to do to improve the indicator that they are working on. They're given an 8-step approach which all of them follow in order to apply the improvement process. Next slide, please. And they are given guidelines of how they should be conducting their meetings so that they can be effective and efficient. Next slide. Those indicator teams meet on a monthly basis as an entire facility so that the system begins to change within the facility and we don't create pockets of excellence just within one facility or hospital. Next slide, please. We also give them tools to help them with improvement, to have a look at data for improvement. So one of the tools you see in front of you is a barometer, which helps us to track the difference between current performance and target. Next slide, please. And the next tool is called the step-by-step, where we have unbundled implementation. We developed step-by-step guides for every single priority indicator. We went to facilities, we mapped out how an ideal process map should look if you are going to implement that specific thing. We then put it in a checklist, which is something which most people understand at a facility level, and we have provided them the step-by-step guide of what they should do. This gives them a baseline to understand where their gaps are so that they know how to address those gaps. Next slide, please. That step-by-step is accompanied with a data guide on the right-hand side, where we teach them to collect data about their work performance, so that that data can be compared to their outcome data, so that they can then identify the gaps in their performance. Next slide. I'm going to be drowned here in any second. The next few slides, again, next slide, you will begin to see the kinds of data that we're looking at. Next slide. To unpack not just how we are working so that we can analyze our own work, next slide please, but also how the provinces and the sub-districts and districts are also working. In this last slide, which I will present before Ruth kills me, is in order to understand the impact of what it is that we are doing, we have tried to unpack our data, because at a national level, you're not going to see the impact as quickly. And so when we unpack the data, you can see that we are having incredible impact when we really try to unpack that data. The last slide, please. Next. Okay. Two of these, there's 2 handbooks that are available on our website for you to download. The first one is the Operation Patuma Manual, which I've just spoken about now. The second one is a how-to guide, which I developed with the IHI a number of years ago, where we take PDSA cycles and we unpack them and teach you around how to develop PDSA cycles. Last slide. I hope that I've inspired you to be the change that you want to see in the world. We need to embed the change within our systems and stop just trying to create these small pockets of excellence. The embedding lies in the kind of guidance that we can provide. Thank you.